stage name. Can you guys hear us okay?
Yeah, I can now.
Yep.
Tell us when. All right, 3, 2, 1. All right, we are back with the Doctors In, Dr. Greg Scher, and we have a new sponsor I want to talk about. I'm delighted. Encompass Health, the nation's leader in rehabilitation. And I cannot be more grateful for the care they give to our post-spine and brain patients. And they do a great job. They will even tour you around their facility before you have a surgery so you know where you'll end up if you need rehab. And so we're very grateful for them. Just an exceptional leader in the community. Today is very special. We are continuing on a series of discussions with super specialists. And as much as it pains me, I am going to talk to people who deal with another organ, the heart. But these are small hearts. So we're talking to Dr. John Love and Dr. Brigitte O'Connell, two colleagues of mine who deal with pediatric hearts, so rather small ones. But I want to start this discussion off about a 1962 Volkswagen. And Dr. John Love is here. Now, you've been doing pediatric heart catheterizations and especially valve repairs, but that all started because you learned about valves in cars. Tell us about this car. Was that your first car?
Yeah, it was my first car. And, growing up in California, street bugs were kind of the
oh,
thing.
Sure.
So,
like the old surf V-dubs with the exhaust out the back.
They'd modify them and pull them down low. And so when I started college, a friend of mine who was good at this kind of stuff, we shopped around and found an old 62 bug. And then we towed it to the dorm, and then we took the engine out and snuck it into the room. And so
get out of town, really?
That first semester we hid it from the RA and all that kind of stuff. And
what?
So we rebuilt the engine and got the thing running, and it was pretty sweet.
I can smell the marijuana in that story.
Yeah, we had to hide that.
Like, John Love and his love bug.
There you go.
That's right.
He must be like, wow, check out these valves, man. Do you still work on cars now?
No. That was that time in my life, and then medicine just took all the other time.
I know how that is. You didn't paint flowers on the side of this thing, did you?
No, we didn't. No.
I mean, what year are we talking here?
This would have been 1980.
Yeah, that's back. I was 11. And you were
not born.
Yeah, I know. You weren't even a glimmer in someone's eye. Bridge, so you and I have this great shared history, which is that we went to the same medical school, and we get to talk all about that for a second. But were you always so that's upstate New York, just in the Hudson Valley, just north of New York City, New York Medical College. Great experience for, I think, both of us.
Yeah.
Did you grow up there?
Yeah, so I grew up in the Hudson Valley, just north of New York City in Orange County, which native New Mexicans may not
Orange
be.
County Choppers.
Yeah,
remember
that's
that show?
right. That's right. It's not far from. That's where West Point is, the military academy.
Oh, you were up that far?
Yeah. Mm-hmm. Okay. So I was born and raised in Orange County, and I knew I always wanted to do medicine, but I was also a dancer. And so I actually moved to New York City after high school to pursue dance and did that for several years before returning to school and doing my undergrad way down in Long Island at Stony Brook University, and then ultimately made my way to New York Medical College for med school.
All right. So, yeah, I ended up there. I was at Columbia for a long time as a pre-med, and then I had a whole another career doing computers in medicine. And that's how I ended up in New York Med. I was the first webmaster that they ever had. And I was a programmer and did all this kind of stuff and network and installed the computers. And it was, we used to go to these meetings, and there'd be like the vice president of finance and like the medical director. And then I would be like, yeah, I'm the webmaster. And they'd be like, it was like an old school Catholic institution at the time. They're all like, go sit in the back of the bus, kid. What are you talking about? But then people were like, we really need you. So it was a cool time. It was an interesting way to kind of become a medical student, which was I became part of the administration of New York Med. And then they realized that computers in medicine was the future. And God, I can't believe how long ago this is, but and it's really one of the reasons that I kind of got into med school and got into my residency is that I could translate the new science of computer science to
That's
medicine.
awesome.
Yeah, it's really kind of an interesting left door.
Yeah,
Yeah.
it was a great experience. I had really wanted to potentially land there for med school. As you know, we're kind of at the mercy of where you get your acceptance
yeah.
letters, and but being a native to the Hudson Valley, knowing the story of the Children's Hospital there, which
Right.
we had talked about earlier, that Maria Frere Children's
Yep.
Hospital,
Amazing place.
Yeah, it's really great. And so knowing the history of that growing up in the Hudson Valley and hearing the story of Maria Frere.
Can you? I remember it vaguely. I mean, I think they lost a
Yeah,
child, right?
Yeah, so she was actually around the same age as me, but she was, I think, around like 10 or 11 years old when this had happened. But she had succumbed to rabies and was
right.
in the adult hospital at that time, and it went too long unidentified.
And they didn't have.
And so
a children's
unfortunately,
hospital.
yeah, they didn't have a children's hospital in the area. The closest was either up in Albany or to go down to New York City to like
Right.
Columbia, Sinai, NYU. And so the family, after losing their daughter to rabies, had really invested everything in building a children's hospital. It was a real grassroots effort.
Yeah. Oh, I was there at
Yeah.
the time. They hadn't even broken ground, and then over the years I was there, they built it. And I mean, it's very impressive. Anybody who may go to that area.
Yeah.
But yeah, it was such a heart-wrending story.
Yeah.
I couldn't remember why. I have several children that play in the grass all day long, and they act like they have rabies. I don't know. Maybe you can come over and fix them somehow. So then, and you got a couple of kids, right? You were at
Yes,
soccer
I
today.
do, yeah. So just the trajectory of my training and everything, I had because I danced for several years in New York City doing regional theater stuff and some commercial things, and then joined a contemporary company. The trajectory of starting a family was while I was in the thick of medical school
sure.
and training. So I actually took 2 gap years around having my kids.
Cool.
I'm sure you are both familiar with it. Sometimes the experience cannot be super supportive of starting a family.
Yeah.
And so during that time, I continued my pediatric cardiology research through New York Medical College while in medical school and residency, and then had my 2 children. So I have 2 daughters. They're 9 and 6. So
Okay.
they keep me on my toes for sure.
I got a 7-year-old who might be looking for a date sometime in the next 10, 15 years.
Sounds good.
So briefly, and then, so how did you pick pediatric cardiology? I understand from John.
Yeah, it's really funny
His
actually
story.
going with my dancing background. I'm from a very large family, and if you talk to like my siblings and stuff, they would tell you like I thought I was going to be an orthopedic surgeon. My grandfather was an orthopedic surgeon who had died before I was even born, but I knew his story through my father.
You have to work on cars. Then
Yeah.
if you're gonna do that, so.
And so I really thought with I had it all planned out, right? As us type A physicians do. I was like, I'm going to become an orthopedic surgeon, and I'm going to do
Right.
sports medicine, and I want to work at the Harkness Center for Dance at NYU, and that's what I'm going to do.
Right.
And then as a medical student, I joined every interest group to just make sure I kind of knew all the things that were my options. And
There were too many dudes. What-
it wasn't that,
Hey,
listen,
bro.
I can hold my own around
With
that.
the
I have
bros?
6
Okay.
brothers, right? So I definitely I spent time in the OR as a medical student in my like first and second year, just watching cases because they would let us in if you were like in the interest group or whatever. And I stood there and I was like, this is not for me.
Yeah.
So I actually spent time in pediatric neurosurgery because I knew I wanted to do a surgical type of
now you
procedural
piqued my
field.
interest.
Yeah. And then I realized for neurosurgery, I was so focused on making sure that the neurosurgeons didn't have to shave so much of the child's hair that I offered to just do all the braids. And so I thought, okay, well, maybe this isn't for me if I'm more focused on the child's hair than the actual procedure.
So your choices were hairdressing or pediatric
Exactly.
interventional cardiology.
Cardiology. So it was actually on my surgery rotation as a 3rd-year medical student. I was at St. Vincent's in Bridgeport, Connecticut.
Oh yeah, of course.
And a smaller community hospital, but very robust services. And that was one of the things that was awesome about New York Med is you had an opportunity to rotate at all types of different places. And spending time at St. Vincent's, all of the surgeons were spoken for in terms of preceptorship.
Okay.
And so they had just kind of overbooked the amount of medical students. And when I reached out to both New York Med and then speaking with the team at St. Vincent's.
This was the one spot that was left?
There was a cardiothoracic surgeon who sometimes would take medical students,
okay.
and he didn't have any residents or anything like that. He had a PA that worked with him, that scrubbed with him. And so I said, you know what? Yeah, if he's willing. And his name was Al DeMeo, Dr. Al DeMeo. And the first day he says to me, my job is to convince you not to go into surgery. And I thought, okay, well, this
that's
is
helpful.
sad.
Yeah.
And I thought, why? You love your job. You're so good at it. He actually did a lot of thoracic robotics, but it also did do cardiothoracic stuff. And so the first day we're walking to the OR, and because I did all of his cases with him, and then I would do all the add-on surgery cases. And so we're walking to the OR, and he said to me, you know, I'm going to take this time to just teach you all about cardiology, which you both know is really challenging in the first 2 years of medical school. It's usually taught by PhDs and not MDs. So it's a different perspective. And I was like, if you had asked me, I never would have ended up in cardiology. Yeah. But being in that situation, he said, pick any spot in the circuit. Just, it could be a red blood cell in the toe. It could be in the head. You pick it and he said, this is just glorified plumbing and electricity.
Exactly right.
All right. We got to come back to John and get his backstory before we start talking again about his love bug. That's just a fantastic story. So this episode is going to be dedicated to heart valves and car valves, and we'll figure out if we can make the connection. Excellent. I'm here with Bridge O'Connell and John Love, two of our interventional pediatric cardiology doctors. It's a great pleasure to have them here, and we're going to talk about stuff I know nothing about. Remember, your organ supplies my organ, and we need to understand that.
That's right.
Beginning. All right, we're going to take a break. We'll be right back. 96.3 News Radio KKOB. Give us a couple minutes, and we'll be back on the air. All right, we are back, and I made a terrible mistake, so it's I'm going to make sure I correct myself. Bridge O'Donnell, not O'Connell, and I think I did that because the dean of the medical school where you and I trained was O'Connell. Did you know him before?
Yeah.
I don't know if he's still alive.
I'm not sure.
Around,
yeah, but he retired while I was there.
Yeah.
Like when I started, he was still the dean.
He was like a very imposing dude, and he gave me my chance. I mean, and I knew him pretty well, but he was like, I never saw him smile. Yeah. He was one of those old school, wore a white coat all the time. And
they had a couple of faculty too that were very much that old school medicine, which I now looking back have so much respect for.
Yeah. No, I agree. All right. Well, anyway, so John went to University of Maryland, where my mother was one of the first medical students, female medical students. She graduated in 1957, I believe. I think she was only number 3 in the whole history of the University of Maryland. And we had a long history with that. My great grandfather was the governor of Maryland, believe it or not. And so my family roots go back pretty far in Maryland, and everybody was supposed to go to the University of Maryland. And of course I ended up in New York. But so that was the beginning of your career too. You stayed on there and had an academic career, or what?
Yeah. Well, I did my cardiology fellowship up at Yale. And then through that, my first job was then at the University of Maryland. So I began there in 1996.
Okay.
I probably cursed the program because I was there a year and a half, and then everyone quit and left to Johns Hopkins, and then I was the only one who stayed. And
well, it's something about less competition that's always good, John. I don't know whether you drove them out or not.
Yeah. And so I kind of had to carry the University of Maryland all by myself for several years while we were rebuilding the program. But I guess it kind of threw me into the fire, and had to start doing things as a young faculty all alone that I wouldn't have done necessarily.
Were you a research guy too?
No, I wasn't. I was pretty pure clinical. And so being alone and carrying a division, that's all the time you had.
I can't imagine. Yeah. Well, I do it every day, actually. What am I saying? So let's get into why you do what you do. Like, John, why do you remember your first case? Like, why? I mean, it's so specialized. It's interesting to me.
Yeah, I mean, as out of fellowship, my first solo case was a pulmonary valve.
So
And
hence why you like valves. so
yeah,
much, right?
exactly.
He's like,
Yeah.
I've seen this on
Full
a.
circle.
I've seen
full
this on a
circle.
full 4-cylinder.
Yeah. So, and back then, the technology, we weren't replacing valves. We were only ballooning valves that weren't opening correctly. And so,
Can you just briefly explain to the audience what a heart valve is, what a pediatric heart valve problem looks like? What is the issue?
yeah. So, the heart has 4 chambers, and as flow moves through the heart, they have to go through doors.
Yeah.
They open and they should close well, and they should open completely. And then
And the reason for that is to build up pressure, I think. right?
exactly,
Yeah.
it helps propagate flow. So it's
Got it.
efficient,
Yeah.
And so when we talk about stenosis or problems with blood flow out of a valve, typically it just doesn't open well, or it's small. But
Or the opening's becoming tight, I guess.
yeah,
right?
exactly. And so back in the 70s, there was a Dr. Khan,
Okay.
a woman who was the first one to do this procedure where if you cross the valve and leave a wire out in the pulmonaries, you could take a balloon and inflate it in the non-opening valve, and you could kind of break it in a way that then all of a sudden it was able to open well. And
So, and this is not open heart surgery, just so the audience knows. You're doing all this with through an artery.
yeah, we're going through arteries and veins in the groin typically.
with an X-ray machine, and just
Exactly.
guiding it through the heart.
Yeah.
That's so cool.
And the equipment changed, but the procedure's exactly
Yeah.
the same as what 1970s, but
Yeah.
very successful. But that was my first one. I think
And we're talking on a baby, or that was an adult.
yeah, it was a baby.
Oh, wow.
Yeah. So we typically, because it's like usually they're born with it, and if they're very severe when they're born, we have to do them.
So this is like life and death stuff.
Yeah.
We got to get up there and open this valve, otherwise the blood's not going to flow through the heart correctly, and the
Right.
kid could die.
Right.
Yeah.
Yeah.
Okay.
Yeah. So, I think for me, the idea of pediatric cardiology, I knew that I loved procedures going through residency
Right.
and all that. It was known to everybody.
Yeah.
I could be working in the ER and someone would be in the PICU, the ICU, and
Right.
they were told they were going to put a chest tube in, and they'd come down and say, "I'll cover you down here. If
You
come
go
up,
run and do it.
do it for me." So, but I think what drove me, as opposed to surgical interventions and procedures, was the idea that cardiology seemed to be the only one where not only did you do the procedure, but then you got to take care of the patient lifelong.
Oh, right. The critical care part.
So you get to fix things, but at the same time, they don't leave you. You get to stay with them. And
That's cool.
so if you do a baby intervention, you get to take them all the way through 18. And
Oh, you're talking like you see them for a long
they're in
time.
my
yeah.
clinic.
Yeah.
Yeah. So
Wow.
we see them grow and go to high school,
That's amazing.
and now we're
And you're
doing
like, I saved your
adults.
life.
Yeah, I told them over
Don't you
that.
forget it.
Yeah.
Yeah, don't do drugs. I saved your
Yeah.
life.
I have that discussion a fair amount with my meth patients.
Yeah.
Wow, that's interesting. Yeah, some of the most I tell this story a lot, but some of the most meaningful conversations I have with I do a lot of spine repairs for people who are using IV drugs, and the bacteria gets in and eats their spine away. I have to go rebuild it with massive surgeries, and then of course, I love doing the surgery part of it, but sit them down afterwards and say you have a chance here.
Yeah.
And about 7% of them actually do decide to quit after I give them that
Yeah,
story.
yeah.
And then the other whatever percent comes back, and I get to do another surgery on them at some point. But some of them you can get to stop and intervene in their lifestyle and have a long, meaningful relationship. I get some Christmas cards from people who changed their life, had kids, straightened out,
Yeah.
so that's kind of cool. All right. So you're a new person, a recruit
Yeah,
to our
fresh.
state.
Yeah.
And I was talking to Dr. Gupta, who was on a couple of weeks ago, and he came from California. And, I was a little bit involved in that HB 99 where we were trying to get reform of the legal issues in the state. It's hard to recruit someone like you. You are probably one of 4 or 5 in the whole state. Is that right?
So no, there are 2 of us in the state,
Sitting in
and you're
the
looking
room.
at them.
Oh, I thought there was. Is there nobody
No,
at the
there-
university?
Well,
He's
that's me.
university.
Oh, yeah, right. You're-
and then
okay.
I'm at press, and so we're the only 2.
So
in the
cool.
state
You
of-
guys, I'm like, it's like royalty.
We're an anomaly.
Jerry, we got royalty
Um,
up in here today.
Yeah.
Wow.
So I can tell you, came about because my brother has lived here for about 10 years, and he's been for years, he was trying to get me to come out and visit and everything. And I just didn't have time because of
You were like,
training.
balloons, I don't know.
And I knew I wanted to do intervention, but so I would look and see, kind of who was here. And at the time, John has a long-standing history at UNM, and there was another individual that was at Presbyterian at the time. And so it just given the population and the amount of congenital heart surgery that was happening, there wouldn't really be a need for a third person necessarily.
Okay.
So I just
are patients going out of state?
Yes.
They still are, right?
Yeah.
Yes.
How do we, because Bill Stein, the cardiothoracic surgeon, I intend to drag his butt on this
Yeah.
show. But he and I talked about this. Like, I'd like to help, retain some of these patients. Would you say it's like 50% loss, or like how bad is it?
I think it's more.
Oh my God.
But John could probably give you a better ballpark.
No, I think that's probably right. When I came here, I was recruited to university to rebuild a non-existent cath program,
Right.
and which was hard because they didn't have a surgeon.
Right.
And eventually, Bill and I were presenting at the Pediatric Society of New Mexico meeting, and he had just arrived. And
Okay.
so we were there just to kind of discuss what each institution was doing. And the question that kept coming up from the audience was, why can't you people work together?
I keep trying to figure that out myself. They have a neurosurgery residency that needs our help. Like, we have all this volume and they need more cases. And so why can't we collaborate? It's really hard to get over that. How did you get over that divide?
So, because that was one of the reasons why so many kids initially were all going out of the state. There was this riff. And so we were sending kids to Lucille Packard out at Palo Alto.
Oh, wow.
And so we could not ever. So Bill and I sat down and we just decided, let's do it. And we finally got administrations to finally let us work back and forth.
Yeah.
And I think the beauty with Brige and I is we're not looking at separate institutions. We're looking at ourselves as we are the interventional team for the state of New Mexico, and no matter which hospital you're at.
Yeah, that's brilliant.
Yeah.
I think that's the right answer.
Yeah.
It's really necessary. I think it's just in the congenital heart community, the general consensus is that every state deserves and should have their own congenital heart program.
Right.
And
it transcends, the patient care transcends.
It's
the
really
rivalry.
hard for these
Yes.
families to go out of, and that these are some of the sickest patients that we see in medicine. And it's really hard on these families, especially when they're diagnosed in the fetal period, to then be told they potentially have to go out of state. And if they have other children and other obligations.
Oh my gosh. Yeah. I can't even imagine.
A lot.
Yeah.
And so that was a huge motivator for me when I learned about.
They're going to go to Colorado or California for like 2 months, right?
Right.
I mean,
Yes.
we're not talking
sometimes
just a day
to
trip.
deliver. Sometimes the families
they
are
have to
going to
deliver up
deliver
there.
there,
Yeah.
and
Wow.
then they're having their babies there, and then they're there for months to a year to a couple of years, and relocating their entire life. And it's a lot to ask of the families. And I feel like if we have the expertise and we have the resources and the infrastructure, or we can build more infrastructure to
Right.
make that happen, we have an obligation to do so. And so when I first learned about the patient population, I did my due diligence and came for a visit with my brother. And he had a friend who is worked for Pres for a very long time in hematology and oncology in the adult world. And he sat me down and just gave me the lowdown on kind of what's the history of medicine in the state, what's the history of insurance in the state.
Yeah.
Now, while he doesn't do congenital cardiology, he very much had a sense of things of what the population looked like. And my heart just melted, and I thought, this is something that could be
It's a good
really
playground.
Yeah. And I felt like also just me being a second career for me, knowing that if I landed at a big academic center, I may not have as much of an opportunity to build something. And I really wanted to bring my skill set to help something grow.
It's high reward.
Yeah.
working in
Oh,
this
I
area.
imagine.
Yeah.
Yeah. We got to take a break in 1 second, but I have an analogous story, which is that I just kind of started doing what are called kyphoplasties or vertebroplasties, which is 90-year-old people who fall down and they get a crack in their vertebrae. I know this because I had a sports injury years ago that was just like that. And you can't even pull the covers up at night. You can't even stand. It's so horrible pain. And nobody will do these cases. It's a simple needle into the bone that's fractured, and you put cement in it to solidify it. And I always thought it was kind of beneath me. I'm like, I'm doing, crazy brain surgery and pedicle screws and all this stuff. I'm not, well, I'm going to let somebody else do it. Well, these people really haven't had anybody to go to. There's some interventional radiologists will do some of it, but it doesn't pay well. Well, I just started doing it because I had an open spot on Fridays, and I kind of fit in 1 or 2 cases. And just yesterday, I did a 90-year-old. Took me 7 minutes, and she can stand up and walk again.
Yeah.
And I mean, it's all the difference
Wild.
between her getting pneumonia and not making it. Why? Because a needle for 7 minutes. The satisfying ones sometimes are not the gigantic, risky surgeries, which is funny, interesting. All right. Anyway, we're going to take a break. This is a great discussion. I'm here with John Love and Breege O'Donnell. I got that right this time. We're going to come back and we're talking about valves, mostly pediatric valves, and sometimes on cars. So call us. Actually, I guess we can't do calls today, right? All right. So we're taping this, and we're going to just give a plug for Encompass Health, the nation's leader in rehabilitation. You're listening to 96.3 News Radio, KKOB. I keep thinking it was live. I keep thinking it's live.
That's what you're used to doing.
Yeah.
Yeah.
Well, so the big joke is, I talk about brain surgery and people call up about their prostate. I think I told you.
Yeah.
I got to make it up. I'm like, I don't know. So we're probably 3/4 of the way through, I guess.
Time flies.
Is there anything you guys want to talk about? I'll kind of talk about how patients can find you and that kind of thing.
Yeah.
But anything historically or whatever,
No.
or about the current. Okay, whatever.
I think the
Ready to go?
flow has been good.
This show is not a substitute for medical advice. Please consult your own doctor for information and advice on your specific medical condition or questions.
All right, we're back. The doctor is in. We got John Love. We got to get back to a discussion with you about your hobbies, which are so fascinating to me. And Breege O'Donnell, who is a second career super specialist and a great recruit. So these are the only 2 pediatric interventional cardiologists in the state. I thought as a brain surgeon in the state that I was important, but looks as though you guys are eclipsing me. So thanks.
We're not minimizing that.
No,
well,
no.
Not at all.
I feel so much better now. Anyway, so what I do in my spare time is what my wife tells me mostly, and that is, go clean up the horse poop and that kind of thing. So we in our spare time take care of a bunch of horses and kids that ride them, and she does some horse rescue stuff that we're going to grow. We're growing our horse farm. So you guys should both come out and ride a horse or pet a horse or stand back and look at the horse, whatever you want to do. But you do bonsai trees. Like
Yeah.
what is involved in all that? Do you have to go to Japan to study to become a sensei in this or what?
No, you don't have to, but we take classes with Americans who did their training in Japan. So
Okay.
so the roots are still strong to
Got
be
it. It's good
traditional.
metaphor there.
Yeah. So, but I think from my little experience, I think American bonsai is a little more modern, and there is a trend to not go pure traditional, so the trees are so variable, and they represent, the region that you grow in. Like,
Really?
like we'll have one seeds that grow here naturally. So we bonsai those trees and things that are just naturally off the.
Can you explain what it is exactly? Because it sounds very labor intensive, but there's an art to it. I don't know what bonsai really means.
Yeah, the term kind of says little trees.
Oh,
And so the concept is that, you want a tree to stay smaller than it normally would be, but when you're finished with it, it should have movement, but look like a bigger tree, but just in miniature. But
I see.
a lot of people think of it's all 6 inches or a foot, but you can bonsai things that are 4, 5, 6 feet.
Okay.
You're just taking trees that normally would be bigger and you're keeping them small. So So it's good root structure. So you put them in really small pots, and that's where you get
Interesting.
into like engineering, how you wire it in there to be stable so it
Okay.
doesn't tip and move and all this stuff.
But is it a constant like pruning and
Yeah.
and figuring out?
Yeah, it's everywhere from, you have to do a lot of repotting to keep the roots healthy. When you're ready to style, so get the trees healthy, but then you have to prune down and shape them the way you want them to be. So it's a lot of little wiring that you do
Oh, I
to
see.
bend the branches and shapes that you want, movement and all this kind of stuff. So sometimes you're just letting them go wild, but then when you're ready to style, you prune them down and wire them.
Are there books on this? I guess you
there's
learn how to make certain shapes.
Yeah,
or-
there's tons of books out there. My wife, she got into it first, but she got to the point where like before big cases or after big cases, she would notice that I'm just anxiety ridden, and
Oh, wow. Yeah.
so she said, "We're going to find you something to calm you
Oh,
down."
sure. Yeah.
So she took me to Denver, and we had classes with this one gentleman there, and it's calming. It's working with
So
these trees.
are you out in your workshop for a couple hours working on these trees? Is that you get away from your
Yeah,
professional life?
you could be 8 hours on one tree one
Wow.
day. Yeah, so just getting it ready to style, and you don't even notice the time flying because it's just you're so intent on the tree and you and it's for me it's a great experience.
Are there valves in the
awesome.
trees? I think there are,
There
right?
probably
the roots have valves. It's all about valves.
There must be.
What do you do to relax? You still dance, Bridge?
So that's a great question. I actually don't dance as much anymore. Every once in a while, I'll try to grab a class when I can. And all of my training was in large cities where I had that kind of access. But of course, time always makes that difficult. In medical school, when I went from dancing, 6 days a week to not dancing at all and just studying constantly, I needed an outlet. So I actually got
Yeah.
into long distance running
Oh, wow.
and really into Pilates. And fell in love with it. So I actually got certified in Pilates like a crazy person
cool.
while I was in medical school. And with the long distance running, I've done a bunch of half marathons, and I actually just completed the LA Marathon
Oh, wow.
a couple
You're
of
kind of an
weeks ago.
overachiever. I think.
Stop.
I don't know why you're not a brain surgeon. We need to talk about your life choices at some point.
Oh, so I got into long distance running, and it's the LA Marathon was like it was my first one. I've never
Is
done a
it
marathon
pavement the whole way?
before. Yeah, it is. Yeah. And I did it to fundraise for the Live Like Braun Foundation, which is in honor of one of my mentors from UCLA, Dr. Dan Levy,
Oh, cool.
tragically lost his son last
wow.
May. To a car accident. He was hit by a car by a drunk driver. And so they started this foundation. So I did fundraising for that, and it was like a great motivator. But for me, it was also like a very symbolic period of like finishing training and finishing the marathon.
So I have
goal
a
is-
philosophical question
Yeah.
for both of you. I got into neurosurgery because one of my best friends was actually murdered. He was
Oh, I'm so
he
sorry.
had stopped along the side of the road to help some kids who were out for a thrill kill, and they shot him with. And it's a crazy story. I'm writing a book about it if I can ever finish it. But it seems like these tragedies. I mean, the Maria Fieri massive children's hospital wouldn't been built without that tragedy.
Right.
Your friend, and I imagine in the kind of work that you do that there are tragedies, right? And so obviously a lot of us are motivated to go. I spent a lot of time trying to repair that hole in my life, let me tell you.
Yeah.
And it's not ironic to me that I've taken a lot of bullets out of people's heads, right?
Yeah.
Right.
But are there cases like that do either good or bad? I mean, the cases that either maybe John can talk about that you remember that that really marked your career, made you want to do better, or that you saved. I don't know, something.
For sure.
Well, yeah, I mean, I don't know if I can pinpoint one specific case. There are the cases that make you want to get better are the ones in which you did, like I guess there was one post-op single ventricle who was getting his what we call a Fontan, and it was all
So the heart only has one chamber.
It has one ventricle.
So he's just a deformed
and,
heart. kid,
yeah, and so
Wow.
they're doing plumbing,
Sure.
to reroute flow so that it can work in
Survive,
this
yeah.
one system with one ventricle. And he was having so many problems, and we went back to the cath lab every night for
Wow.
like 6 nights and
Trying to save him.
Yeah, because you'd fix one thing and then another one would show
Yeah.
up. And eventually we were able to make him better, but we just weren't satisfied with how
Yeah.
good the outcome was. And he lived for a while. But it makes you then appreciate all the newer technology that comes along. I think the interesting thing for Breege and I is the spectrum that we're on, because
Mhm.
I'm the old guard who was with when we didn't have a whole lot of
Right.
tools,
Right,
and
right.
and technology advances so much now. And she's coming out of training, getting to have worked with all
Oh, I
these
love
cool
that
things.
you guys are working together. I think it's so cool. And I too, I guess I'm long in the tooth now. I've hired a couple, 3 guys all at once that just came out of fellowship. And it amazes me what they know. And it also amazes me what they don't know about the politics and survival and that kind of stuff. Like, learn from him.
Yeah.
John's
I'm
been
not,
around.
I'm not taking it for granted.
You don't have
Trust
a gray
me.
beard yet, and
Yeah.
it could happen to you. All right, we're going to take another break. Jerry's giving me the universal sign. If you need rehab care, check out our sponsor. We got Encompass Health. We send a lot of patients there. It's the nation's leader in rehabilitation. You're listening to the Doctors In 96.3 News Radio KKOB. We'll be back. All right, we are back for our last 6 minutes. We have to wrap this up. All right, it's been an amazing discussion. I'm so impressed with the both of you guys. I think your fellowship training and trip through med school and residency is probably slightly longer than mine, which is very upsetting to me because I like to complain about how I was tortured for decades.
To be fair, I extended my training though, because I knew
That's
that
right,
I was
that's
going to
right.
be coming as the one interventionalist at Presbyterian, although knowing that I was going to have support
Right.
from John, I did extend my training. So yes, I was a PGY 8,
Yeah.
but that technically would have been PGY 7 had I not extended.
Yeah, it's interesting. In med school, I chose not to do surgery because I kept going, wow,
Yeah, I
that
know.
many
Yeah,
years.
mhm.
Yeah,
And then I ended up.
Next thing you know.
Yeah, exactly.
Exactly.
My recollection is there's not a lot of cardiothoracic surgeons around right now. For a while, it was like impossible to get those spots, and then I don't know, where is it now? Is it hard to be you guys, or is it just you got to slug through it and kind of persist? Are there no spots? Like, what's the situation?
So it's interesting because from a pediatric interventional job market situation, it ebbs and flows. I think the last couple of years we've trained more than we have
Needed, yeah.
jobs for. And so that there's been a little bit of a flux there. So in just talking to my mentors from Seattle Children's, I think there's a push to maybe pull back on training for a couple of years
Right.
if they can. But I think what also helps is programs like where I trained, where I also got adult congenital interventional training.
Oh, cool.
So at University of Washington and at institutions like that, they can sometimes flex their training with the adult congenital fellows that want to go into intervention, and then the
Got it.
pediatric congenital fellows that are going into intervention.
So wait, just take me through that. So 4 years of med school, then what was your whole trip?
Yeah. So it's 4 years of medical school, 3 years of pediatric residency. I completed mine at Cornell in New York City, and then 3 years of pediatric cardiology fellowship. So with the exception of a few fellowships, all pediatric fellowships are 3 years in training, including research time and everything. And then intervention is another year. There is a push to make it 2 years, which in my
Wow.
humble opinion, it should be 2 years
Yeah.
because the field has gotten so complex in terms of what we're being asked to do.
Yeah.
The risk from the OR is now being transferred to the cath lab.
Yeah.
And so that's why I extended my training.
Can you elaborate on what you just said there? I think
Yeah.
I understand that, but
Yeah, of
what
course.
do you mean by that?
So in congenital cardiothoracic surgery, we have there have been ways to develop technologies that have developed to allow us to support our cardiothoracic surgeons where they can hold off on opening the
open heart
chest
surgery. Yeah.
and doing neonatal repairs if we can buy more time, particularly for single ventricle patients, whether they have a single left ventricle or a single right ventricle. We can do things like stenting their ductus, which is that little remnant vessel between the aorta and the pulmonary artery, to buy them more time, because bigger sometimes is better, and then they can get these patients bigger. So I think it's what makes our field so attractive, is that the innovation that's come out of the field and the continual growth. To think that, not that long ago, there weren't the transcatheter pulmonary valves that we have and the technology that we have. The first pediatric stent was just approved last September, September of 2024. It's the Minima stent, and it is for coarctation of the aorta and for pulmonary artery.
Coarctation means that it's
the narrowing of
very
the aorta.
stenotic.
Sometimes.
John, did you foresee this? Did you know when you got into it that you were going to be doing more of what the heart surgeons do? Like, how did you see it?
No,
I didn't foresee AI, and here we are.
Yeah.
No, because the technology, the era of the devices. So when
we are in that. I guess. Okay.
And so when I was coming out of training, we would close these PDAs, the vessels that we were talking about. We had coils, and they were.
You could seal things off, and that's about all
we
you
could do it, but they were a pain, and doing large defects was a problem. We were ballooning things that were needed to be opened. And stenting for coarctation, narrowing the aorta, narrowing in the pulmonary arteries was just beginning to take off.
Right.
And then all of a sudden, in the late 90s, devices for closing holes started coming out. So for me, it's been a journey of constant retraining and education, learning things as they come. And for Breeze, it won't stop, because we're.
So wait, so have you learned something from her?
Well, yeah. I mean.
Oh wow.
Oh really?
It's just, she's coming out of training, working with these devices and these valves, and so with her senior mentors, she's learned tricks that, I hadn't been able to teach myself.
That's
yet,
cool.
So.
So since you've been here, Breeze, is there a case that stands out?
Oh, we just had one.
We can't talk about specific names or anything,
of course.
But what generally?
So I will say that there's no shortage of complex congenital heart disease here in New Mexico, and that has really been.
Let's
eye-opening
stop
for
the
me.
outflow and get you guys busy.
Yeah, and we just
he needs a new VW.
Yeah, that's right.
So it was actually a pulmonary valve case in an adult congenital patient who had been lost to follow up because the care.
Like we're talking a teenager? Or?
No, in her 30s.
Oh, okay.
And had come with a complex valve, had multiple valves placed previously at an outside institution, and then all at
the old redo surgery. Those are fun.
And then also here. And so we were able to, and she had developed what we call a fistula because of all the hardware that was in there between her pulmonary artery and her aorta. There was a hole.
Okay.
And so we had this great opportunity to help her because she's not a surgical candidate, and we successfully were able to restent her left pulmonary artery and get a new pulmonary valve in.
The big question is, did she hug you?
She did.
I bet she did. You guys are so talented. I am more than pleased to have kind of introduced you to our listenership, John Love and Breeze O'Donnell. The only two people doing this stuff in the state, taking care of pediatric hearts with endovascular techniques. I'm thrilled to call you my partners in all this, and we're going to build a room 26.
That's right.
Where we can do hybrid open and closed heart surgery at the same time, and I intend to steal it on weekends and holidays for my stroke program. Thank you guys so much. What a delight. And maybe we'll have you back on. We'll talk about some more cases and other stuff. And thanks again. You're listening to 96.3 News Radio KKOB. We're sponsored by Encompass Health, the nation's leader in rehabilitation. And we'll see you next time.